I'm a practicing radiation oncologist, but yes, I will talk today about immunotherapy in lung cancer. It's really a huge topic. I will try to complete within the time. So my topic, immunotherapy in lung cancer, when and how to use it best. So my disclaimer, a few slides taken from the ESMO Academy lecture. So these are the key discussion points: how immunotherapy works, key breakthrough shaping immunotherapy in lung cancer, landmark trials and updated guidelines of small cell, both the limited stage and extensive stage, as well as metastatic non-small cell lung cancer. Then immunotherapy in adjuvant or neoadjuvant setting, as well as unresectable setting, real-world data, and some highlights from the ESMO 2025. So at first, how immunotherapy works. So here, T cell is the main issue. So T cell normally attack cancer, but become exhausted sometimes or maybe suppressed. And then cancer cells use the PD-1 and PD-L1 pathway to hide from the T cell. So anti-PD-1 drugs like Nivo or Pembro, as well as anti-PD-L1 drug like durvalumab or atezolizumab, blocks this off switch, allowing T cell to attack again the cancer cells. And anti-CTLA-4 drugs, that is the EP or temolizumab, act earlier, helping activate T cells to the antigen presenting cells. So in short, this checkpoint inhibitor removes the brakes of immune systems so that it can better kill the cancer cells. And this is the timeline of immunotherapy in lung cancer, and you can see from 2015 to now 2025, in the last 10 years, there are so many trials and so many indications invented in the management of lung cancer with immunotherapy. Now start with the small cell lung cancer. So in a small cell limited stage lung cancer, this is the Adriatic trial where after concurrent chemoradiation and after if there is no progression, then Durva versus placebo was used or randomized in Adriatic trial. And in this trial, there was, you can see in the graph that there was benefit with the addition of durvalumab in terms of overall survival as well as the progression-free survival. And now it established the role of durvalumab as a standard of care in this setting. So ASCO guideline updated their guideline in 2025. They included the durvalumab, that is the immunotherapy, in their guideline after the concurrent chemoradiation in limited stage small cell lung cancer. Now the extensive stage, that is IMpower 133 trial, where the extensive stage small cell lung cancer were randomized to the comparison done between the conventional chemotherapy arm, that is the carboplatin tripartite, versus the conventional chemotherapy plus atezolizumab. And they also found the overall survival and progression-free survival benefit. So this also established chemoimmunotherapy as a new standard of care in case of extensive stage small cell lung cancer. Another study, that is Caspian study, where Durva were used, and in this Caspian phase 3 study, adding durvalumab into the platinum etoposide chemotherapy in the first line setting also improved the overall survival benefit and making it as a standard of care. So ASCO updated their guideline in 2025. They also, in case of extensive stage disease, added the immunotherapy, that is the durvalumab. Now non-small cell lung cancer. So to treat a non-small cell lung cancer patients, we need to consider many things. Initially the patient factor, like performance status of the patient, if there is any autoimmune disease or any history of transplant, what is the goal of the care, patient preference, etc. And also we need to consider about the histology as well as the targeted mutations and also the PD-L1 expression status. So in 2025, the advanced non-small cell lung cancer, to use immunotherapy that can be categorized into 3 types. PD-L1 expression more than 50%, between 1 to 49% and less than 1%. And you can see in PD-L1 more than 50%, immunotherapy monotherapy is an option. I will come in detail about the evidences. In ESMO guideline, advanced PD-L1 more than 50% non-small cell lung cancer, they also included the immunotherapy, monotherapy as a standard of care. Let's see the evidences. 3 trials, 3 study, Keynote 024, and Empower 110 and Empower Lung 1. So same type of patients like untreated stage 4 non-small cell lung cancer with PD-L1 expression more than or equal to 50%. So in Keynote 024, pembrolizumab was used. In Empower 110, atezolizumab, and in Empower Lung 1, cemiplimab was used. In all the 3 trials, you can see the median overall survival benefit with the monotherapy of immunotherapy in comparison to the conventional platinum doublet chemotherapy. And they also showed the median duration of response benefit and objective response rate benefits in all the 3 trials. So there is a question, in case of PD-L1 expression more than 50%, can we use both the combo like immunotherapy and the chemo in case of treating the PD-L1 expression more than 50% patients? So what is the real world data? So in case of metastatic non-squamous non-small cell lung cancer with high PD-L1, the real world data showed similar overall survival and progression-free survival benefit between the immunotherapy alone versus immunotherapy and chemotherapy combination, except in never smoker who benefited more with the combo therapy. So finally, for more than 50% PD-L1 expression, monotherapy is the standard of choice. Never smoker can be benefited from the combo, but other that combination is the option. And you can see in the right side of my slides then that in case of non-squamous or squamous, there are so many combinations of immunotherapy and chemotherapy in different trials. Now come advanced non-small cell lung cancer with any PD-L1 level. So this is the ESMO directed guideline. So they are telling about the immune checkpoint inhibitor plus anti-CTLA-4 and chemotherapy in this arm. Let's see the evidences. In case of non-squamous non-small cell lung cancer in advance, Keynote 189 uses pembrolizumab along with the platinum doublet chemotherapy, that is pivitexate and carboplatin or cisplatin, and in squamous arm, that is the Keynote 407, where pembrolizumab were used along with the carboplatin and paclitaxel or nab-paclitaxel. So in Keynote 189, metastatic non-squamous non-small cell lung cancer without EGFR or ALK mutation, combining pembro with the chemo led to significantly longer overall survival as well as progression-free survival in comparison to the chemotherapy alone. And in Keynote 407, paclitaxel or nab-paclitaxel combined with the carboplatin and pembrolizumab improved the overall survival and progression-free survival. And another trial, that is Empower 131 trial, where in case of stage 4 squamous non-small cell lung cancer, atezolizumab were added along with the carboplatin and nab-paclitaxel and found significant overall progression-free survival benefit, but there is no benefit in case of overall survival, and overall survival benefit was found in case of high PD-L1 expression. So now the question is, where do we use the anti-CTLA-4? That is Checkmate 9LA trial, where with the chemo, comparison was done between ipilimumab and nivolumab, that is the dual immunotherapy as well as the chemotherapy. And you can see, irrespective of the PD-L1 expression, it gives us a better median overall survival benefit with showing broad and durable response, even for low PD-L1 expression. So here, there is a role of CTLA-4, anti-CTLA-4. Another trial is Poseidon trial, where adding tremelimumab along with the durvalumab along with the chemotherapy in the first line setting of metastatic non-squamous non-small cell lung cancer significantly improved the overall survival and gives durable benefit across all the PD-L1 group, even in the low PD-L1 expression. So dual ICI plus chemo is a strong option, especially for low PD-L1 tumor. Is there any chemo-free option? That is checkmate 227. So here, Nivo and EP is compared with the histology-based chemotherapy versus nivolumab alone, and checkmate 227. Here, nivolumab and ipilimumab significantly improve the overall survival regardless of the PD-L1 expression. Now, after the advance, that is the metastatic non-small cell lung cancer, let's see the resectable non-small cell lung cancer and the role of immunotherapy. So, if it is EGFR or ALK wild type, in that situation, after surgery and after chemotherapy, there is a role of immunotherapy. So, if it is PD-L1 positive, there is a role of atezolizumab as well as pembrolizumab, and if it is PD-L1 negative, there is role of pembrolizumab. Let's see the evidence. That is Keynote 091 study, where after surgery and after chemotherapy, it was randomized to pembro versus placebo, and gives disease-free survival benefit regardless of the PD-L1 status, but it was greater in PD-L1 more than 50%. And IM power 010, where atezolizumab was used, and it also give improvement in disease-free survival status, especially in PD-L1 positive cases, and established as a standard of care. And for that reason, the ESMO guideline comes with PD-L1 positive cases, atezolizumab. Now, the neoadjuvant setting, checkmate 816, that is the neoadjuvant trial where Nivo and platinum-based chemotherapy were used in case of resectable stage 1B to stage 3A non-small cell lung cancer. And it led to a great pathological complete response rate that was 24% with the combination of chemo along with the Nivo versus only 2.2% with the chemotherapy alone. And it also significantly improved the event-free survival. So, neoadjuvant chemoimmunotherapy with nivolumab and platinum is now the standard of care for operable non-small cell lung cancer. Let's see about the unresectable cases. In unresectable cases, the mainstay of treatment of non-small cell lung cancer stage 3 is concurrent chemoradiation. And yes, there is a role of immunotherapy after the concurrent chemoradiation. Let's see the evidence. That is the Pacific trial and also the 5-year updated data of Pacific trial, where after concurrent chemoradiation and if there is no progression of the disease, then durvalumab was compared with the placebo, and it gives sustained and durable benefit of durvalumab consolidation after concurrent chemoradiotherapy. It gives 5-year overall survival as well as progression-free survival benefit. And in this forest plot, you can also see the benefit of durva. But one thing we should mention, it was observed that the benefit with the durva was not evident in patient with PD-L1 expression less than 1%. There is another trial, that is Pacific 2 trial, where along with the concurrent chemoradiation, durva was added, and they concluded that among patients with unresectable stage 3 non-small cell lung cancer, durva administration from the start, like with the concurrent chemoradiation, failed to demonstrate any additional benefit compared to the chemoradiotherapy arm. So, consolidated durva following concurrent chemoradiation is the standard of care in this setting. So, when immune checkpoint inhibitor not recommended in non-small cell and small cell lung cancer? In case of non-small cell lung cancer, in case of EGFR or ALK mutation positive, PD-L1 less than 1%, in that situation, we should not use monotherapy, we should use chemo-immuno combination, and we should be aware about the autoimmune disease, active infection, and poor performance status of the patient, as well as any sorts of transplant history. In case of small cell lung cancer, if there is any progression during the maintenance immunotherapy, we should not use, and in case of second line, it is also in the trial still now. Let's one slide from the low dose immunotherapy, because we know that the immunotherapeutic drugs are very much expensive, and in our country, our patient need to pay the cost of the treatment. So it's a paper published in European Journal of Cancer, the expanding access to cancer immunotherapy, a systemic review of low-dose PD-L1 inhibitor strategy. So this review found that using low-dose immunotherapy like anti-PD-1 or PD-L1 drugs can still produce good cancer control, especially in lung, kidney, and lymphoma, while reducing the treatment cost by up to 80%. So most of the data from the low and middle income countries, but many studies had serious biasness in terms of selection bias or lack of randomization. So results should be interpreted cautiously until stronger trials confirm the effectiveness. Some new things from the ESMO 2025. Harmony 6, the phase 3 trial presented in the presidential session about the ivonescimab plus chemo might be a standard new standard of care in advanced squamous non-small cell lung cancer. I don't want to go in detail. Keynote 671, perioperative pembro benefited persist at 5-year non-small cell lung cancer update. So my take-home message, in case of small cell lung cancer, durva after concurrent chemoradiation as per adjudic, and in case of extensive stage small cell lung cancer, chemoimmunotherapy as per IM Power 133 and Caspian is the new standard. Metastatic non-small cell lung cancer, pembro-based and dual ICI regimen expand benefit across the PD-L1 level. In case of adjuvant or neoadjuvant setting, nivo and chemo, and adjuvant setting, atezo and pembro improve the survival in resectable non-small cell lung cancer. And in case of unresectable cases, durva post-CCRT remains the benchmark with durable 5 years. Low and middle income country context, low dose immunotherapy shows real world efficacy, a practical and cost effective approach. Thank you so much for your patience hearing. Thank you.
Thank you, Dr. Arman, for your